I want to welcome all of our attendees, and I want to thank Dr. Alcouloumre-May for spending this time with us this evening. Give a little context of format. We're using one of the Zoom platforms called Webinar. The advantage to Webinar is we have a higher ceiling than we would on Zoom. And also there's a little bit more picture clarity for presenters in this format, rather than all those little Hollywood Square spaces. It'll be more focused here on Dr. Alcouloumre-May. And there is on your lower part of your screens an area for chat. And I invite you to start writing in the chat space. Format-wise, we're looking at about a 45-minute opportunity. First 25 will be laying a foundation, which I'll have. Oh, okay. I've been advised better to do the question and answer rather than the chat. So post in question and answer. And after laying a foundation of conversation with Eric, you will have an opportunity to ask, to have your questions chosen and read to make this much broader and have your voices heard. So I want to again thank Eric for making the time. I have followed, and I'll go back and forth between saying Eric and Dr. Alcouloumre-May. I have followed Dr. Alcouloumre-May's Facebook posts for a couple months. I don't know the exact date that he started. He'll share with us this newfound expression as a doctor in our community, recounting COVID closer to home with kind of a policy lens. And that I have found distinctive and a fresh voice. This is our 6th in a COVID series. We started with a family psychiatrist talking about stress. We had a manager, an expert in crisis management. We had an author of a book on resiliency called Get the Funk Out. We had my son, who's an emergency room doctor in New York. And we had a professor from Chapman who did a talk on anti-Semitism and COVID. Hope I'm not overlooking anyone. And tonight, COVID close to home. So a word of introduction for Dr. Alcouloumre-May. Dr. Alcouloumre-May is an active member of the larger Jewish community of Orange County, a past board member and an active participant at University Synagogue, an active participant in Community Scholar program, and I have had the privilege to join with Eric on CSP events, including traveling to New York City together. And through the years, our children were in school together as well at Tarbut V'Torah. And so looking at your resume, Eric, the first thing that pops for me, only because it's a shared interest, is philosophy. You were a student of philosophy as an undergrad, and I think that's part of the foundation for, as we move forward, talking about your policy interests. First of all, you went to the University of Oklahoma, having grown up in Tulsa. Say a word about going and choosing to go to the University of Oklahoma and studying philosophy.
Well, I'll be very, very honest. Before I start talking, I just want to say hi to all of my CBI friends. And again, I also want to congratulate you on your daughter's engagement.
Thank you.
Now we'll get to business.
Thank you.
I will be totally honest. I started the University of Oklahoma not as a philosophy major, but as an undecided major. I didn't know what I wanted to do when I started college. I knew I was interested primarily in liberal arts, not so much in science, believe it or not. I took a wide range of classes in liberal arts, and it took me 2 years of being an undecided major before I honed in on something, and that was to become a letters major. And letters was history, philosophy, literature, and foreign languages. And I thought I was destined to be a lawyer. Being a Jewish kid, I had two choices. It was doctor and lawyer. I didn't think at the time I had the stomach to be a doctor. I was always that weak stomach kid who would throw up if somebody else threw up. So, and then came Watergate. And Watergate, back in the early 70s, for those of you who are old enough to remember, it really changed my whole outlook on the legal system and government, and really soured me a lot. I had a lot of up-close experience in student government, met people, who were very much involved in that stuff, and it just didn't seem to be the right thing for me. And even going to law, where I kind of viewed it very simplistically and naively as a situation where there's always a winner and a loser, which again, it's an oversimplification, but at the time, being a 20-year-old kid, it seemed to make sense. I wanted to go into something where everybody came out ahead on the same team. I took a class as part of the philosophy part of my major in the history of science, and that sort of changed my whole outlook about science. And I came to understand that the scientists of ancient times were also the philosophers, and science for me suddenly went from being a bunch of memorization and numbers and formulas. It came to being a different way of explaining the world. So I was looking at it from the philosophy side and starting to see that there was a lot of connection between the science and the philosophy. Somehow those things kind of congealed for me. And so not being able to go to law school anymore, I didn't have much choice. And I junior year of college, shifted gears and went from philosophy and letters into pre-med. But my undergraduate degree ended up being in philosophy. That was what most of my background had been in.
Well, for somebody who didn't go to law school, you did the next best thing, which is marrying an exemplary lawyer in Annie. So all of us who know her know how wonderful she is. So that's even better than having gone to law school yourself, for somebody who has gone to law school. So
well, thank you for that. The smartest decision I ever made was marrying Annie. I told her that earlier today.
So how did somebody who defined himself as weak stomach, of all the various subspecialties, specialties, choose emergency medicine?
Well, I'm not going to take your entire hour to tell that story, and there are very various aspects to it, but a couple of things. And one, probably the most important thing I think that affected my decision was one event. And I was finishing my undergraduate at the University of Oklahoma, and I was driving from Oklahoma City to visit parents in Tulsa. It was late at night. I was crossing the bridge over the Saw River about midnight, and a minute or two ahead of me, there had been a bad motorcycle accident. And as I pulled and had to stop, there were maybe 20 or 30 people whose car stopped, standing around, and they're looking at these two people laying on the ground bleeding. And we're all looking at each other and going, what do we do? If somebody had managed to summon an ambulance, they were on the way. But there was a significant period of time where we were all just standing there and nobody knew what to do. And here am I'm going to start medical school in a month, and I had absolutely no idea what to do even first. And I just made myself a promise that I would never be in that situation where I wouldn't know what to do. I'd always be able to do something. I'm not going to be able to maybe carry out everything from the beginning to the end, but at least I'll be able to get things started. And that was something I felt I needed to do as I went into medicine. And then the other thing that I guess led me that way was, as I started taking all of my rotations and training in medical school, I really liked everything. It was fun taking care of kids. It was fun helping the brain surgeon. It was fun trying to figure out, what was wrong with people and piecing it together and going through the whole Sherlock Holmes part of making a diagnosis. And I didn't really find one area that I wanted to do to the exclusion of everything else. And emergency medicine at the time I was training was a very brand new specialty. Before, it was just a specialty that that wasn't a specialty. It was what you did while you were trying to build your private practice. You had to moonlight in the emergency room, and it was a chore. It wasn't something you enjoyed doing. But back in the late 70s and early 80s, it actually became a formal specialty with its own residency. And I went to the University of Southern California, Los Angeles County Hospital program to train in emergency medicine, and I've loved it. And to get past the weak stomach part of the question, it's just a matter of understanding that there's a goal. The weak stomach you can set aside. You just have to figure out what it is you're trying to do and focus on helping people, and it's controlled. I promise I've never thrown up at work.
So I see from looking at your resume that you've been at Hoag Memorial as an emergency physician since 1986, and you have been an active leader there as a chairman at different points, now co-director, and serve on the board of directors of Hoag Hospital. And I did smile to note that you were elected to that role by your colleagues, by the medical staff. Talk for a moment, and this is the kind of the bridge and the segue to focusing on COVID, about your Facebook posts and what prompted you to start writing on Facebook as an emergency physician in our community about COVID.
It's not a complicated answer. It goes back to my wife, and my wife has a very wonderful group of friends who I love and I'm close to. And in the early days, which was a few months ago, February and March, what we were starting to see was a lot of bad information being circulated on social media, on texts between friends, and a lot of it was just crazy. It was crazy, it was scary, and it was clearly wrong.
Give an example of some of the bad information that grabbed your attention.
Probably the single one that I think finally pushed me to actually post something was from a very smart person that I know that sent me this very elaborate PowerPoint that was circulating on the internet, and very believable description of how you kill the virus by taking a hairdryer and shoving it up your nose. Maybe some of you have seen that. I don't remember all the details. It was a couple of months ago, but it was absolutely outrageous. This whole theory that heat will kill the virus, and you have to several times a day hold this up in your nose and let it sit there for several minutes, and stuff like that. I mean, it was just crazy. There was another one I remember was a text that my wife had shared with me. It was a telephone message. It's prefaced by somebody saying, this comes from a very authoritative source that I know that works at a big university hospital. And it listed 8 or 10 things that were wrong, and they're just not true. And just seeing that level of misinformation getting out there and getting people frightened about how they could contract the disease and things that they were supposed to do to prevent from getting it that were wrong, I finally just said, okay, I'm going to post this for my wife's friends and my friends and family. And, probably on Facebook up till then, I only would post pictures of my kids and my dogs and my wife and I on vacation, occasionally some music. I had a couple hundred friends on Facebook. So I put that post up, and it got shared like 1,000 times, which I was very surprised about, because it really was not written for 1,000 shares. It was written for my small, intimate group of friends to try and get them to stop spreading nonsense. And then it just became, every morning I wake up, I see something, I go, oh, that's not right. And I would start writing about it. Another one of the ones early on that got my attention was a physician up in Michigan, I think, named Dr. Jeffrey Van Wingen, who had a Facebook post, YouTube post, telling people how to disinfect their groceries. And I don't know if many of you have probably seen it. It got shared on Facebook, well over 26 million times. So I have my little intimate group of friends and followers, nothing like what this guy had. And it was just dangerous misinformation. And he's very credible. He's a nice looking guy. He's got a ponytail, and And he seemed very stressed as he's giving his presentation. Again, this is back in March when people were really frightened and didn't know what to expect, but we all saw it was coming. And he was telling people to do things like wash your vegetables in soap and water. And a few days later, he had to retract some of that because so many physicians and nutrition specialists said, that's dangerous. If you eat soap, you're going to get sick. You can't do that. And there's no basis for it. I mean, the FDA even back then was pointing out that food is not a means of transmission of coronavirus. So just again, this widespread misinformation, I just felt ethically compelled to share what I felt was actually factual, evidence-based stuff that would help people not be so frightened.
So I always have one eye on the clock. And in that regard, where I'd like you to kind of fill us in, knowing we're going to get into more immediate issues, I looked up today just to double check. I see that California, that Governor Newsom declared the stay-at-home order on March 19th, making California the first state to declare stay at home. 2 months now of COVID since the stay-at-home order. Give us kind of a general overview about Orange County and how Orange County what that trajectory of the 2 months has looked like.
Great question. And it's, when I remember, as all of you say, that Governor Newsom laid down that rule, I thought it was excessive, to be honest. When he first said, everybody has to stay at home, this is what we have to do. It really didn't take more than a day or two for me to realize he did absolutely the right thing.
Why? What happened in that day or two?
I started paying a lot more attention to what was going on elsewhere, seeing what was maturing in New York, especially where your son works, and I'm sure it shared a lot of information with you guys. I became quite frightened that we were going to experience something similar to what was going on in New York, and it happened in Italy and was starting to materialize in Spain at that time, that we were running a real risk of being overwhelmed by a disease that we were absolutely unprepared to take care of. We had been through it with Ebola. We'd been through it with SARS. We knew how to prepare for these things, but these were manageable numbers because we were able to get on top of them very early on in the process. But from what we were reading and hearing and understanding, the horse had kind of left the barn on coronavirus, and it was spreading, and we had to do everything we could do to beef up our systems to be prepared for when this onslaught of patients was going to hit our hospitals. The hospitals then went into high gear, started doing things like canceling elective surgeries, focusing all of their efforts on making sure that there was adequate supplies. We at Hoag were able to quadruple our capacity for being able to take care of intensive care patients. So we spent a lot of time, effort, and expense to be ready. And because the community did what the governor had laid into place, the whole introduction of social distancing had a huge impact. And I really believe saved us from the New York experience.
Say more about what the Orange County experience is.
So what the Orange County experience is, we started seeing cases actually we saw the very first case at our Irvine Hospital in January, as many of you know, and it was a traveler from Wuhan, China. He did very well. Because he was the first case, he was in isolation in the intensive care unit for a couple months, although he fortunately didn't get that sick, but he did very, very well. The experience in Orange County was a handful of cases trickling in. Of course, everybody that had a cough or a runny nose or the flu was sure they had coronavirus. So we were seeing people that were very worried. We didn't have adequate testing early on. You all have to be well aware of. You might get that was ordered or started and you might not for 5 to 10 days. So we were having to put people into quarantine if we were suspicious that they might have it. It turned out the overall rate of positive tests was very low in Orange County, probably somewhere around 8%, even among the people that we thought were likely to have it based on their symptoms. So there were other viruses that were causing some of the same symptoms. But we did start seeing some pretty sick people, and people ending up on ventilators, people in our intensive care units who were getting quite sick, but never at the numbers that overwhelmed our resources. So because we were prepared, because people socially distanced, this was something well within our capacity to take care of. I mean, work is very different for us. We're wearing masks and protective gear for many of our patients that we've never had to do at this rate before. But the Orange County experience has really been, I think, a very positive one because people did what they were asked to do and helped control the disease, because there's no vaccine yet. There's no effective medications to use across the board. So the primary tool to fight this disease is to keep it from spreading.
How relevant is testing as part of that spread containment? And tell us a little bit about what testing has been like in terms of this 2-month arc.
Again, a great question. I mean, in an ideal world, when the first cases started popping up in China in late December, had we reacted a little differently than we did and had testing available when the cases started to hit the United States in January, we could have done like we did with Ebola and like we did with SARS. You can identify who has the disease, you can isolate them, you can trace their contacts, and you can keep the disease from spreading. Once it started spreading, there still weren't tests available to the amount and volume necessary to enact that type of program. It was just too late. The testing had to be done in a big, widespread area where you could predict who had the disease, who they had gotten it from, and who they were likely to give it to, so you could keep your hands around it and keep it from spreading through the community. So testing in that context would have been amazing, but it wasn't available.
What was the reality on the ground here in Orange County, and is the reality now?
My understanding, the reality then was it just wasn't available. I mean, the only place you could get it was from the public health department. The only people who were getting it were people who were sick enough to require hospitalization for the most part. So you could come to my emergency room in the middle of March with symptoms that sure sounded like you had COVID, but if you didn't look like you needed to be admitted to the hospital and you could manage it at home like the flu. Again, the turnaround time on the tests was 5 to 10 days. So me, ramming the Q-tip up your nose and doing the test wasn't going to make a difference what you're going to do for the next 5 to 10 days. You're either going to get better or worse. There wasn't a different medication I was going to give you based on that test result either. So we really had to make clinical judgments about who was sick. And if you were really sick and you're going to go in the hospital, then we needed to do the tests, partly to confirm the diagnosis, but it also had a big impact on where in the hospital we were going to put you. Are we going to isolate you with other patients we think have COVID in that part of the hospital and keep everybody else that much safer? A patient suspected of having COVID, we had to wear the full protective personal equipment, the PPE. Every time we went in, every interaction, you couldn't forget to put this on one time, or the goggles or the mask. Work in the early days of the week. That happened to one of my partners on the first case back from January. He forgot to put the goggles on for one of his 10 visits into the room. So if you can imagine that we're already hearing about how they were burning through all their PPE in New York because of the volume of patients they were dealing with. If you had to be in the hospital for 5 or 10 days waiting for your test result interacting with doctors, nurses, people bringing your food, people cleaning your room, every one of them had to put on the full gear each time and then throw it away. You're going through a lot of PPE. And because you didn't have a test result to tell you you don't have coronavirus, we had to do that on all of our suspected patients. So the tests were more important for that at that point.
Are there tests now?
Yeah, now we have tests. We have tests for the 2-hour turnaround time. They're definitely more available. I know that all of our Hoag Urgent Care Centers have them available. If your doctor is suspicious that you may have it, or you're suspicious you may have it, you can talk to your doctor. They can arrange to have the test done. We're doing them in the emergency department. Again, only on the higher risk people. We don't want people to come to the ERs just to get a test. But if they're sick, we're there to take care of them. But the test results will come back in a couple of hours, and we're still finding a very low positive rate. So the social distancing is still doing the important part of the job of keeping the disease from spreading.
Are you also doing antigen testing at this point?
Well, the antibody testing, we are just starting to do. I just actually had my test drawn a couple of days ago as part of a study of healthcare providers, and mine was negative. It's not being done routinely, and I don't pretend to be an expert on this end of it, so I don't want to get too far afield in this. My personal feeling is that unless the antibody testing is part of an organized program, either a study or a public health initiative that, as far as I know, doesn't exist yet, where they can take that information and make it useful, there's no point in you running out and trying to find an antibody test. The rush to get the test done included a period of time where the FDA was not even screening the tests. So apparently a lot of bad tests have been out there. They're changing that. So I would not run out and get a test today, because if you're negative, you don't know if it's a good test or a bad test. You're not going to change your behavior. If it's positive, they're not 100% sure that a positive antibody test confers adequate immunity that you would have to change that you would change your behavior. So it really, an individual getting an antibody test today doesn't really give you any useful information. So I'm not pushing people to get.
So I read this will be my last question for now, and then we'll start looking, and I'll pick some of those Q&As, or you can pick some Q&As. Today on your Facebook post earlier today, you wrote about how the US is doing comparatively. Why don't you just share a little bit about what you were thinking about today and your perspective on that?
Yeah, so we're number one. No, not something we're particularly proud of.
Number one in what sense?
Deaths. We have the highest number of deaths, and it's sad. I mean, you think, you hear all of these people who are out there saying, "Oh, it's no worse than the flu. In fact, it's not as dangerous as the flu." I mean, I've lived through and worked through tons of flu seasons. I have not seen 90,000 people in the country die in a couple months. It's the leading cause of death in our country today. And I think what frustrates me is, as I write these posts and you've read them and you know it's the conspiracy theories, it's the frustration that you know that there are people out there who are working very, very hard, putting their lives at risk. And I'm not talking about me. I mean, I'm blessed. I'm in Orange County. You guys have done an amazing job of social distancing, which has protected me. It's protected the people I work with. Yes, we take all of our precautions. We're very, very safe. We're very, very careful. But the risk to me is very, very different than what your son experienced in New York and others. I mean, it was breaking my heart to watch on TV and seeing the hospital in Brooklyn, for instance, where the sick patients who should be isolated are in gurneys next to each other, sometimes with a curtain between them, but sometimes they're in the hallway. And I know that if I had 2 COVID patients, walking into a glass enclosed isolated room in full protective gear, I leave that room, take that off, I go in to see the next one, I put a whole brand new set of gear on, I'm very safe, I'm very comfortable that I'm protected. And I'm watching on the news these doctors going from gurney to gurney without the opportunity to change their gear. And a lot of them ended up getting sick, and some of them died. And it shouldn't happen here. It should never have happened here. We should have been prepared for it. And so then you hear all the conspiracy theories and the videos, and they're very slick and well produced, and all of them have a political motivation, pushing them, and it frightens people, and it frightens people unnecessarily, because there's a limited number of things that you can do, and you have been doing them, and you've been doing them successfully. And social distancing is at the top of the list. Washing your hands is second, and then as we start moving back towards something that we're going to someday call normal, for now at least, we need to all wear masks. And just doing those simple things, you don't need to worry about all of the complicated, questions about the numbers of mutations and other things. We got people who should be able to help all of us figure those things out. Right now, all of us need to do what we can do and we can control. And that's really what my posts are about. So I'm encouraged that Orange County's done a good job. I guess I'll wrap this up. I'm encouraged Orange County's done a good job. I'm a little discouraged at people pushing too quickly and getting either too complacent or too frustrated to get this all over with, that they may be putting their lives and all of our lives at risk by not coming out of this in a smart, organized, careful way.
I'm gonna, with your permission, Eric, I'm gonna take some of these questions to broaden the scope. We already have 10 posted, so consider, like just a paragraph answer. But I know who some of these people are, and it always makes me smile when I see them. So Nancy Raymond, who I spoke to earlier today, said, I know Eric from his work with the Maccabea. He was one of our doctors and has always played an important part. Nancy's a nurse who's played an important part in our Orange County community. She asks, do you have an approach to assist those people who have no background in science to understand what the value of vaccines will be as we work towards healing the world?
Well, hi, Nancy. I knew Nancy even before the Maccabee stuff because she was one of our nurses at Hope. I think the vaccine isn't going to help us in the short term. Let's be honest. It's going to be most optimistically 8 months to a year before it's available. I think it will be a critical part of long-term control. And that goes to the whole discussion you've probably heard about herd immunity, where if enough people are immune to the disease, it's much harder for the disease to find people who are vulnerable to spread it to. It is, part of the control of many diseases like measles and mumps and so forth. It's used for influenza. Granted, the efficacy against the flu virus isn't always good every year, but it helps, and it does help reduce the spread. Hopefully there will be an effective vaccine, and we'll get it as soon as possible. That will be the big game changer, I think, for the long-term control, and maybe whatever steps we have to take between now and the availability of the vaccine, to keep the virus under control. Hopefully we'll be able to relax those further and get much, much closer to the lives we had before March.
So I have a pair of questions from a Dr. Linda I know well. First is, what were the early tests, PCR? Take that one. Again, just if you have like a paragraph response.
Oh, I can give you a 3 or 4 word response, but the PCR is the test, the swab that goes up the nose, and that's to see if people have the virus now. So it doesn't tell you if you had it last month. It doesn't tell you if you're going to get it or if you're immune. It just tells you if you currently have it.
And what were the early tests? Were they those kind of tests?
Yeah, the PCR were the tests that they were doing from
the very beginning.
The day we had the test, yeah.
And still are the tests you're doing?
Yeah, my understanding that the tests we're still doing. I've heard but have not seen that there are other ways of collecting it now, like inside the mouth. And there may be some other tests I'm not familiar with, but my understanding is the test that if I order a test to see if you have it now, it's the PCR test.
What's your guidance to people bringing home groceries?
Okay. to me, that question is so easy. And again, because of this, Dr. Van Wingen and really widespread, I think, bad information. First of all, there are no cases. There's been no documentation ever. And you see it on the CDC website, FDA website, a lot of credible places you could look to validate what I'm about to tell you. And I've been saying for the last couple months in my posts. Food is not a way you transmit coronavirus. It's primarily a respiratory virus. And even today, some of the stuff that I've been trying to say early on, you can get it from surfaces, but it's not as big a deal as people have been thinking, and the CDC is now actually saying that. Theoretically, yeah, you can get it from a surface if somebody, wipes their nose, touches the surface, you come along, touch the same surface, and wipe your nose or your mouth. Yeah, you can do that. So how do you avoid that being your issue? You wash your hands. You carry hand sanitizer with you. And you deal with groceries the same way. You don't need to scrub down all of the containers and the boxes and all that because the virus might be living on it. It's to me, it's so excessive and unnecessary, and I haven't been doing it, nor does anybody in my family. So just washing your hands before you pick up things, and when you're done, and the virus is very, very susceptible to being killed by soap and water. It doesn't have to be anything elaborate, but you do not need to sanitize or scrub your vegetables, and certainly you don't want to put any kind of chemicals on your fruits or vegetables. You should wash them with cold water like you would probably do normally to get rid of pesticides and other substances that might be on them, but you do not need to do any special disinfecting of anything.
Phyllis asked, did Orange County have the full complement of PPE?
Yes. And Phyllis, that's thanks to people like you who did the social distancing that we did not have to burn through our PPE. So I know at Hoag, we were very careful. We didn't want to be irresponsible and pretend that it might not be a problem in the future. So we're still very careful about how we do it. We don't, keep throwing masks away that could be reused, or wear them when we don't need to wear them. But we have been very, very fortunate in Orange County not to experience what they have experienced in other places where they had a much bigger crush of patients and had to go through their PPE so quickly.
So Arnold Sugarman asks about people who are asymptomatic and yet transmitters of COVID. Say a little bit about that and the challenge that provides for containment.
Again, because, and I think you ask in your question, you say, how do you track the virus with limited testing? I mean, that's the problem. We're in a situation that I wish we weren't in, because had we had adequate testing early on, you wouldn't have to ask this question. On the good news side, the experts that I rely on at Hoag, who are most knowledgeable about this, have said from day one that asymptomatic transmission of the disease is not, maybe doesn't account for more than 4 or 5% of actual cases of people who get it. So even though people may have it, if they're not coughing and sneezing and have secretions, flying around, it's unlikely that you're going to see them as a significant part of the problem of disease spread. So it is a little more complicated because we don't really know the true incidence of the virus in the community, but it's probably less of a big deal than just think of Orange County compared to New York, where people are, living in a much denser area. They're all on public transportation so much more. They're much closer walking on the street, packed into restaurants, and not taking any precautions during the period of time all this was spread. That's really how the virus spreads most of the time. So, hopefully soon there will be an adequate infrastructure to support widespread testing so we can figure out what the true incidence is, and then go through the process of appropriate isolation, contact tracing, and control the disease.
So our questions keep growing, and which means we're going to go a little over time with your permission, Eric, but I'm going to have to get you to give like shorter paragraphs. Jay
I'll
Witzling, I don't know if you know Jay. Jay is dear to many of us. He notes that Orange County reports that today is the single worst day for deaths and new cases. In that light, what does the summer look like for opening summer camps and pools? And I'll add, and Orange County at large.
Jay, that is a great question. And I just saw, just before I came on, I saw that the death rate had gone up. I didn't get a chance to really go through all the numbers carefully. But what we have been seeing, and it's easy to find the numbers at the Orange County Public Health, which I look at every day, about the new cases. And all along, I've been less concerned about the number of new cases in total, because we don't really know how many. That's totally dependent on the number of tests you do. The more tests you do, the more cases you're going to find. So if you do 100 tests and find 20 cases, you don't know how many cases you would have found had you done 1,000 tests or 10,000 tests. You don't really know the true incidence. So the numbers that are more important to me are deaths, hospitalizations, and people sick enough to be in the ICU. So those are the numbers that I look at, and all those numbers are available. If you look at the models that we were using and still continue to use that come from the University of Washington, the IHME graphs, they predicted that California would have peaked in about the second or third week of April. And that put us on course to be able to reopen on, actually the date was supposed to be tomorrow, May 21st. That's what we were predicted a few weeks ago to head towards starting to relax social distancing. And all of these numbers were predicate upon people complying with social distancing. Once you stop doing that, the model's no longer accurate. But what we're seeing is that our caseload, although it's still well within the capacity of the hospitals to take care of, the numbers aren't dropping like they were supposed to, and they're creeping up. And I'm not surprised it's reflected in the deaths. Remember, the deaths you see today are from people that got sick 2, 3, 4 weeks ago. So we don't know if that number is going to go up or down. I think it's going to go up, unfortunately, because we're seeing more people in the ICUs and more people in the hospitals this last few days as well. What does that mean for opening summer camps and pools? I'm not a public health expert. I don't think it's a great idea unless there are a lot of guardrails and rules in place that I don't know what they would be that would keep people separate while they're using these types of facilities. I don't know how you do that in a summer camp or a pool. So I would be very skeptical about seeing that happening. I think it's too soon.
There are a couple questions about ventilators. Both Bob Sklar and Judy B. Say a word about the use of ventilators in your experience in the ER with COVID. And do patients have a choice not to have the ventilators? And how commonly are they being used now in the ER at Hoag?
Again, it's a great question. And ventilators, that could be a whole hour discussion about ventilators. But ventilators we have always used. It's not just a COVID-specific treatment. A ventilator is what we use when somebody isn't breathing or they're so sick we have to make them unconscious and breathe for them. Ventilators have a lot of uses for critically ill people. What they found with COVID, because of the way the virus attacks the lungs, is that people can't breathe without being on them. And there are a lot of weird, very technical things about COVID that we've learned that make it different from other diseases that end up putting people on ventilators. And what you probably have heard, if you've ever watched Governor Cuomo's press conferences, for instance, that most of the people in New York, as well as in Italy, who ended up on ventilators ended up dying. You know, that they're already very sick, no matter what reason they're put on a ventilator, but you have COVID and you're on a ventilator, they have as much as an 88% chance of dying on the ventilator. Our experience at Hoag is much different. So I talked to my intensive care specialists who end up managing the patients on the ventilators, and over 80% of people are going home and coming off of the ventilators. So that's good news. I think part of it is because, again, we aren't overwhelmed like they were in New York when they were having to, they may not even have enough people to help manage the people on the ventilators. So it's not automatic. If you come in and you have COVID and you're sick enough to be in the hospital, there are many, many things we'll do before we put you on a ventilator. A ventilator is sort of like a last resort. If we don't put you on it, you can't get enough oxygen and we can't continue to do the other things to keep you alive. Yes, you could refuse a ventilator, but if you're sick enough to require one, it's basically you're saying, I don't want to be treated and I'm going to die. We don't necessarily put people on ventilators because we want to. We put them on because it's a necessity.
In Orange County, are we using plasma with antibodies? This is a question from Helene Coulter, as a treatment with people with COVID at the moment. And let me just broaden that. What is being done for treatment in Orange County? What drugs? What's the current best practice? But start with her question first of plasma, specifically in antibodies.
Yeah, I think St. Joseph's was the first hospital to be using plasma. We're doing it now at Hoag as well. And I know that there are programs where they're trying to find people who have had the disease, who are testing positive for antibodies on a reliable test. They can now donate plasma, and that can be used to treat patients who are very sick, to use those antibodies and infuse them into the sick patient and have those antibodies fight the virus. And that's found to be very effective. So that is being done. There are no proven treatments yet for the virus, to be totally honest. We participated in a trial of a drug called remdesivir that you may have heard about. And that is showing promise in terms of shortening the length of time people have to stay in the hospital and the severity of their disease. So, but that's not what you get if you just have a mild flu-like coronavirus illness. That's if you're sick enough to be in the hospital that you would be considered for treatment like that. Most of the current treatments are being done as part of organized studies now. So, so the standard of care really is if you're not real sick, you isolate, you quarantine, you wash your hands, you take care of yourself, you protect others, and you hopefully get better. If you're getting sicker, you end up in the hospital. And then whether you're eligible for some type of a study, depending on what hospital you're at and what's available, then they're trying things. But there still is no consensus treatment for the COVID yet.
So your friend, my friend, Mark Kerner, raised this question before I think you responded to the grocery question, but as an extension of it, and it's my opportunity to do a shout out to Mark and thank him for the little blurb he wrote about you.
Very sweet, thank you.
Last mailing. So transmission on coins and paper money, how much should we be concerned about what we're touching?
Well, we should be concerned about what we're touching. Again, as far as I know, there's no cases of where you can pinpoint, oh yeah, you handled that coin, that's what happened. So I have a secret weapon I carry around. These are getting harder to find, but it looks like this. And before and after every transaction I do, if I'm handling paper money, if I'm touching a keypad or have to do a signature in a store, I do this afterwards. And a lot of the stores have these the big version sitting on the counter so you can do it afterwards. It's all about washing your hands, and that will protect you. The virus doesn't, despite what you've read in experimental situations, the virus is really pretty delicate. It doesn't live hours and hours on surfaces that you're likely to be able to pick it up and catch it from. But anytime you handle anything, touch something that it's not you in your own house, you need to just wash your hands.
So an extension of that concern is from our preschool director, Sharon Alkin. She says that as they're considering reopening the preschool, teachers are concerned about spending the day with little children and then potentially carrying something home to older members of their family. What would you say to those preschool teachers?
Wow, that's a tough question. I'm not sure I want to go there, but I'll just tell you what I'm thinking. Any schools and preschools and big groups, synagogues that are planning on reopening are going to have a bunch of rules and a bunch of guidelines, and people have to follow them. I mean, there's no way we can do this forever. We can't stay locked down and isolated until we have a vaccine, for instance, and develop herd immunity. So some of this stuff is going to have to come back, but it's not going to be the way it was a few months ago. Someday it will be, but it can't be in the next several months. I mean, the question reminds me of when we started seeing patients with COVID, and a lot of healthcare providers felt that they couldn't go home to their families because of the risk that they might pick it up and carry it home. You know, the advice of our infection prevention people at Hoag was no. And I'll tell you what our head doctor does for that, the head of infection prevention. He sees more patients than anybody because he sees all of the ones at Hoag. So he wears the regular PPE when he goes in to see them. He washes his hands when he leaves the room. He wears his regular clothes home, and he spends time with his family. And I've adopted the same thing. You just have to be careful, but you can't be super paranoid. You know, you have a big room full of preschool kids. You know, if there probably is going to be temperature screening before they're allowed to come in, you know, check them for symptoms every day. You're going to have to just do that, or you do run the risk of you know, these little petri dishes they call preschool rooms, you know, people spreading them to each other.
Two closing questions, and the closing question will be your opportunity to pull this together, since we're now 5 to 6. We don't want to go past 6. Bottom line, the series of questions is what you were just talking about. So on one foot, what's your guidance on how things should reopen, let's say between now and the beginning of university school year, and what that would look like? So where do you see things in the next 4 months for a limited window? And then the closing question, and you can choose how you want to close, but it is one of the questions on the feed, and that is, why should we be paying attention, or let me reframe it, what should be the role of science in going forward? And those two, of course, are intertwined and looking for the next 4 months.
I think the second question answers the first question, and again, I'm going to preface this. So I'm an emergency doctor, and I started writing a couple things on Facebook, and that's why I'm here, not because I'm an expert at public health or epidemiology or immunology and all of that. And I don't want to give you guys the wrong impression. So my answers should be limited because I am not the expert. What I do is I rely on the people who are the experts, the people who understand the science, who are doing the research. And there are a lot of them. They're all over the world, and they're interconnected, and they're communicating with each other, and they're working together, not competing with each other. They're trying to find a way out of this for all of us. So those are the people that I rely on. So the role of science is, that's what's going to save us, is real science, not conspiracy theory, not a bunch of doctors who may have political motivations and therefore want to prescribe a certain drug because it fits in their political ideology, not a mass reopening of society because it's not a big problem, but it fits a political narrative. It's really got to be the science, and it's got to be free of the politics. And that's what's going to get us through this. So it's not the advice that I'm going to give you. It's the advice I'm going to take from the true experts in public health who are going to advise our policymakers, and hopefully our policymakers will listen to them free of the extraneous noise and tell us what steps we have to do. And we know it's going to involve social distancing to some extent. We know it's going to involve wearing masks in public. We know we're going to get our temperatures taken 100 more times in the month of June than we have in the last 10 years. We know all of those things have to take place to try and protect us. So I see inconvenience in the next several months. I don't see us being normal for a while, but I'm very optimistic that we will find normal. But a lot of that depends on all of us working together and not working against each other. And that's where we have to go.
Well, I want to thank you, Eric, for giving me, and I'm sure our listeners, we had 91 screens, which is about 130 plus people. And it's a joy to have gained, your perspective, which that philosophy training is, part of it, meaning a bigger policy perspective, as well as the details of what's going on close to home. It's with gratitude for all of us that you do the work you do. I know that when my son John was choosing emergency medicine, I connected him with you to help him decide. And one of the things you said to him made a big impression on him in making that choice, which is you said something to the effect of, I know that in the work I do, people are better off for having met me than if they hadn't. Actually, the way he heard it as well is that each day you felt that you had made a big difference in the world, and that inspired him. And this conversation helps ground me as part of the collective of all of us who've been with you on this conversation, to know that we have a challenge, that physical distancing is making a difference, that although things spiked today and we're not out of it, that we are working it, and things will yet emerge. One last word for you. Anything else you want to say as a closing word?
No, just thank you, and thanks for having this conversation with me and inviting me. And it's nice to connect with my friends at CBI. And again, I really want to thank all of you, because this really isn't, me. This is all of us as a community doing what we have to do to protect each other, and we need to be respectful. We need to be kind. We need to, watch out for each other. And a simple act like wearing a mask when you're going to the grocery store, it shouldn't be an ordeal. It shouldn't be a political statement. It should just be something we're doing for each other, and try and think that way as we work out the other inconveniences that we have to go through to get through this and get society back to what we want it to be. So thank you.
So last word, I just want to say you had a national audience. I want to shout out to Dr. Joe Rubin for some of the comments he helped share with me as part of this. A delight. Thank you, Dr. Eric, for your giving us more of a sense of COVID close to home. My best to Annie and the family. Thank you.
Thanks. Thanks, everybody.
All right,
Bye.
be well. Bye.
Take care. Stay safe.
Thank you.